Good afternoon, everyone. Welcome back to our lovely room here, the Health and Social Services Subcommittee on Appropriations. I'm Delegate Emily Shetty, joined by my amazing subcommittee members here today. Today's hearing, we have one budget. It is the MDH Medical Care Programs Administration. It is a big one, and so we have 14 witnesses signed up in addition to our DLS analysis and our agency witnesses. So we'll start with Ms. Ann Braun, who will give us the highlights of her presentation. And you can start when you're ready. Thank you.
Thank you, Madam Chair and members of the committee. As you said, I'm presenting the budget analysis today for the Medical Care Programs Administration, or Medicaid. So on this first page, you'll see that the fiscal 26 allowance is about $13.3 billion. That's just under $270 million less than the fiscal 25 budget. However, I will note that the fiscal 25 budget includes approximately $510 million to cover shortfalls in fiscal 24. And so once you account for that funding, the fiscal 26 allowance actually increases slightly. So I will, as you said, hit the highlights of this presentation. So I will be going pretty quickly, but I'm happy to answer any questions about anything in the document. So turning to page 9, Exhibit 2 shows that Medicaid and MCHIP served 1.55 million Marylanders as of December 2024. And so this exhibit shows that 87% participate in Health Choice, which is the state's mandatory managed care program. The remaining 13% of participants are generally those in nursing homes or who are dually eligible for Medicaid and Medicare, and they receive their services on a fee-for-service basis, and so outside of the Health Choice program. Within the Health Choice program, participants can choose from 9 MCOs for their health plans. And so then I'll move to page 11, which begins performance analysis. The first section discusses MCO quality. And so MDH conducts multiple activities to collect quality assurance data and monitor MCO performance. The analysis focuses on HEDIS measures. Those are used by 90% of health plans nationally, and they allow comparisons across health systems. Exhibit 3 shows each MCO's performance on multiple measures compared to the national HEDIS mean, and this shows that all but one MCO performed worse overall in calendar 23 compared to the prior year. Additionally, this exhibit shows that more than half of Health Choice participants are enrolled in the 4 lowest performing MCOs. MDH is asked to discuss the reason for MCO's declining HEDIS performance, and the department also recently announced that it would be changing its accountability expectations for the MCOs, and so the department is asked to describe what method they would use to determine HEDIS performance issues that might lead to penalties or sanctions. The next discussion notes that in addition to the existing requirement that MCOs must receive accreditation from the National Committee for Quality Assurance, beginning with the calendar 2025 agreement, MCOs must also attain a health equity accreditation. And so MDH is asked to provide the current status of health equity accreditation across MCOs and to clarify when the new requirement would be enforced. So then moving on to page 15, I'll start a discussion of the next 2 items that have to do with MCO incentive programs. This first section covers the calendar 2023 results from the Population Health Incentive Program. Under this program, MCOs may earn up to a certain percentage of their capitated rates for achieving performance benchmarks or demonstrating improvement on measures that are selected by MDH. For calendar 23, these measures related to participants' access to asthma medications, diabetes control, lead screenings among children, and other measures, and those are shown on page 16. Exhibit 5 shows each MCO's results on those 8 measures, and the results that are starred shows places where MCOs were eligible for improvement incentives. All MCOs are reported at least one measure that was rated as strong or higher, and so that made them eligible for some kind of incentive payment. And then all but 2 MCOs had at least one measure that was eligible for improvement incentives. The next exhibit shows how about $19 million, and sorry, that's exhibit 6, shows how about $19 million in total incentives were paid out across MCOs. And so this shows that all plans received at least some performance payment, and that ranges from United Healthcare receiving about $350,000 to MPC receiving $5 million. The program allows for second round payments if MCOs meet certain benchmarks, but in calendar 23, no MCOs earned a second round incentive. So this left $17.2 million unallocated, but MDH used $8 million of it to pay for the health equity incentive, and I'll discuss that in the next section. And so DLS recommends reducing the remaining unallocated $9.2 million in fiscal 25. And then considering the fiscal outlook, DLS recommends reducing the fiscal 26 budget to provide for a lower share of capitated rates under Population Health Incentive Program. And so, as I said, the next discussion has to do with health equity incentives. And so under this program, MDH offers up to $8 million each year to MCOs based on their enrollment in certain local jurisdictions that have high socioeconomic disadvantage. On page 22, Exhibit 7 shows the payments made to each MCO for their calendar 2024 enrollment. The distribution of the payments is not significantly different than the health choice enrollment statewide or overall. And so the analysis notes that other new programs, such as the Enough grants administered by the Governor's Office for Children, look to target investments at the neighborhood or the census tract level. And so MDH is asked to discuss whether it has considered basing these incentives on neighborhoods that are eligible for Enough grants, and then also asked to provide the membership data that determine the calendar 24 payments. The last performance analysis section has to do with application processing. And so I'll briefly go over this. Exhibits 8 and 9 show the processing times between income-based eligibility groups, and those are processed by the Health Benefit Exchange, and then the more complex non-income-based groups, and those participants are those who qualify due to their age or disability status, and they're processed by the Department of Human Services. A recent audit of the Maryland Health Benefit Exchange found that it had not requested supporting documentation for applicants that reported no income. And then OLA found that state wage records indicated some of those applicants had incomes that were higher than the threshold to be eligible for Medicaid. I will note, though, that during the pandemic, MDH had received a waiver flexibility to auto-renew participants who had no income, but this applied to eligibility renewals and not new applications like OLA was discussing. And so MDH is asked to provide an update on this audit finding and any corrective actions taken, including whether Medicaid applicants who are found to be ineligible have been disenrolled. So then I will turn to the budget discussion. And I will jump to page 27 to discuss items related to fiscal 2025. Last year, $1 million was added to the budget to expand the Assistance in Community Integration Services program, but this full amount was reduced in July when BPW approved cost containment. There was also $500,000 added for assistance to medical daycare providers, but MDH has indicated that it does not plan to spend this money due to uncertainty of the legislative intent of the funds. There are 5 deficiencies in the budget plan that add a total of $1.37 billion. Most of this funding is added to cover higher than expected enrollment, higher healthcare utilization, and inflation. And I will note, as I mentioned earlier, that some of that funding is meant to cover shortfalls in fiscal 2024. On page 29, Exhibit 10 shows the results of the MCO risk corridor agreements, and that's an agreement that MDH and the MCOs entered into to share in savings or losses when healthcare utilization was uncertain during the COVID-19 pandemic. MCOs annually spend a percentage of their capitated payments on eligible medical expenses, and then MDH and the federal government would share gains or losses with the MCOs depending on the band that percentage had fallen into. Based on aggregate MCO results in calendar 21 and 22 combined, MDH received state recoveries of $51.6 million. And so that funding was recovered in October 2024, but it's not yet reflected as savings in the budget. And so DLS recommends reducing the deficiency appropriation by that amount to account for those savings. I'll now move over to the fiscal 26 allowance. On pages 32 and 33 is the list of proposed budget changes. I'll actually skip ahead because I'll be covering most of the major budget changes throughout this presentation. And so going to page 34, this begins the discussion of 4 BRFA items that affect Medicaid. The first is an increase in the Medicaid hospital deficit assessment, which would increase by $50 million in fiscal 25 and $100 million starting in fiscal 26 and on an ongoing basis. This is an assessment that is paid for mostly through hospital rates, and then the special funds collected provide general fund savings in Medicaid. And so the budget accounts for those savings through contingent reductions of $46 million in fiscal 25 and $92.5 million in fiscal 26. This fund swap is one of the only significant actions taken in the budget to create general fund savings in Medicaid. Another BRFA provision would create a new special fund called the Medicaid Primary Care Program Fund. This would be supported with hospital payments collected by HSCRC, which would then be used for primary care initiatives under the AHEAD model. MDH reported that $30 million from HSCRC is expected to be collected and then support the fund in fiscal 26 and 27. The budget currently has $16 million in general funds budgeted for this purpose, and so DLS recommends deleting that general fund appropriation in anticipation of special funds supporting that cost. To support primary care services in coordination with the AHEAD model, MDH plans to use this funding to establish a Medicaid Advanced Primary Care Program that would start July 2025. This would operate similarly to the existing Maryland Primary Care Program by distributing care management payments to participating providers and administering quality incentive programs. MDH is also providing a rate enhancement for physician evaluation and management fees to increase rates from 98% to over 100% of Medicare. DLS is requesting a report from MDH and HSCRC on these initiatives and amending the BRFA to make 2 technical corrections related to this provision. And so then covering the third BRFA provision, this begins at the bottom of page 35 on budgetary transfer. This provision would allow MDH to transfer funds by budget amendment across its programs in fiscal 25 and 26. Annual budget language is added so that certain MDH programs restrict funds to their budgeted use and then prevent transfers that might create deficits in entitlement programs. And so the list on page 36 shows the funding restrictions that the legislature applied in fiscal 25. DLS recommends rejecting the BRFA provision to keep funding restricted to its budgeted purpose as it is currently set in fiscal 25. And DLS also recommends adding the annual language restricting funds for Medicaid and MCHIP to their budgeted purpose again. This year, the language would allow transfers to Medicaid behavioral health reimbursements. And so the final BRFA provision authorizes the governor to transfer $10 million in balance from the Maternal and Child Health Improvement Fund to the general fund. The BRFA of 2021 created this fund to be supported through HSCRC hospital assessments to pay for maternal and child health initiatives in Medicaid and FIPA, Prevention and Health Promotion Administration. In current law, the use of this funding expires at the end of calendar 2025. But there are departmental bills that would extend the termination to calendar 2027. However, due to underspending, the estimated balance at the end of calendar 2025 would be $14.1 million, and DLS recommends amending the BRFA to increase the authorized transfer to the full amount of is estimated to be left at the end of this year. So then moving on to page 37, this discusses program realignments in MDH. As of January 1st, MDH had realigned its health home program from Medicaid to behavioral health. And so deficiency withdraws the funding for fiscal 25, but the program is still budgeted under Medicaid in fiscal 26. And so DLS recommends removing the funds from Medicaid as a technical correction, as it will be supported through the BHA budget moving forward. The next discussion is on the longstanding Medicaid Enterprise Systems Major IT Project, or MMT project. The allowance provides $143 million for development across the 14 components of this project. Each part is discussed in an appendix at the back of this analysis. I will note, though, that there have been several delays, and in July, BPW approved a $15 million reduction in general funds. Those are budgeted under DO-IT for this project. And even after the reduction, DO-IT reported a balance of $20 million that could be used in fiscal 25 once MDH reported its plans for the funding. And so MDH is asked to provide a status update on this major IT project. Exhibit 13 on page 39 reflects special fund support for Medicaid. As mentioned, the hospital deficit assessment shows an increase. I will highlight one particular special fund that's discussed on page 40. So MDH administers the Senior Prescription Drug Assistance Program, and that's supported with entirely in special funds. As shown in Exhibit 14, that fund is expected to have a balance of $12.8 million at the end of fiscal 25. In fiscal 26, the budget includes a transfer of $5 million for behavioral health spending and then $3.1 million to DBM for state retirees transitioning to the Medicare Part D program. However, this use was authorized in the BRFA last year, but it was only authorized for fiscal 25. And so DLS recommends adding a BRFA provision to make this an allowable use of the funding in fiscal 26 and on, and that would align with the budget. Then moving on to a discussion of provider rate increases, Exhibit 15 outlines those rate increases budgeted in the allowance. As mentioned earlier, physician evaluation and management fees would be raised from 98% to over 100% of Medicare rates. That is because the Medicare rates were most recently reduced, but the department doesn't plan to apply that same reduction. And so considering the fiscal outlook, DLS recommends reducing the $12.2 million for this rate enhancement. The 3.5% rate increase for MCOs drives most of the rate increase growth. During the rate setting process, MDH accounted for expectations that overall health needs or health acuity would be higher for Medicaid recipients after the unwinding from the pandemic. This trend didn't materialize at first. And the adjustments gave MCOs higher payments while Medicaid participants seemed to have lower health needs or lower health acuity. As a result, MDH plans to recover about $29 million from the MCOs this month to account for that trend. And then this adjustment was expected to be much higher at one point, but has been since written down. And so in recognition of the acuity adjustment, MDH had set the rates mid-year in 24 and for calendar 25 to be higher in the range to be considered actuarially sound, since they were expecting a larger recoupment of funds from MCOs. And so, however, MDH would normally set the rates at a lower level within this range to be considered actuarially sound. And so due to recent trends, DLS recommends reducing the funding set for MCO rates to be at that bottom level of that range. Calendar 25 rates were set while health acuity was still lower than expected. And so because it has increased more recently, MCOs now will likely need an adjustment to cover that higher health acuity. And so the budget includes $124 million for this adjustment. So then moving on to a discussion of long-term service and supports providers, that includes nursing homes. Those providers receive a 1% provider rate increase on a discretionary basis in the budget. On page 43, this exhibit shows that LTSS providers have received significant rate increases in the last decade. This includes accelerated rate increases, as the 4% increases planned for fiscal 25 and 26 were accelerated to January 1st, 2024. That was in line with the accelerated minimum wage increase. And so considering these recent rate increases and there being no mandate for a rate increase, DLS recommends reducing the 1% provider rate increase that's budgeted in fiscal 26. So then discussing home and community-based service providers under Medicaid in particular, these providers received additional enhanced rates that were supported with federal American Rescue Plan funds. Beginning in November 2021, these providers under Medicaid received a 5.2% rate increase, and that was made ongoing even as the federal funds expired. And so DLS recommends reducing home and community-based service provider rates by 2% due to the expiration of the federal support. So then moving on to Exhibit 17, this begins the discussion of enrollment trends. Exhibit 17 shows how Medicaid and MCHIP enrollment had steadily increased over the pandemic and reached a peak 1.75 million average participants in fiscal 23. That was just before the unwinding when disenrollments resumed. And so fiscal 24 and 25, year to date, you're seeing slight enrollment declines, but generally the disenrollments throughout unwinding had been lower than projected. This was partially due to a system error on how the state conducted automatic renewals, which led MDH to pause procedural disenrollments. And those are cases when participants didn't complete the renewal or they had outstanding documents that they didn't turn in. MDH also implemented federal waiver flexibilities that would ensure eligible participants keep their Medicaid coverage. As those temporary flexibilities have expired, enrollment is continuing to decline. There was also another system error that MDH is reconciling with the exchange to be sure that disenrollments correctly apply both to the health benefit exchange and to the Medicaid payment system. So these flexibilities and then the more recent system errors have especially impacted the ACA expansion group. And so that group is expected to account for a larger share of disenrollments moving forward. MCHIP enrollment has continued to grow, so that is kind of going against what the other groups are seeing in terms of enrollment. The MCHIP group is seeing enrollment even higher than the levels reported during the pandemic. That program has the highest income threshold at 322% of the federal poverty level, and so it's possible that as children with lower household incomes are disenrolled from the traditional Medicaid program, they are then being placed in the MCHIP program, and so that's partially why MCHIP's enrollment is still increasing as the other groups show decreases. Turning to page 47, this exhibit shows enrollment forecasts assumed in the proposed budget and projected by DLS. Both forecasts anticipate the fiscal 25 enrollment will decrease compared to the legislative appropriation, and that's due in part to the end of the federal waiver flexibilities and also the system reconciliation process. And so both of those trends are leading to more disenrollments. I will note, though, differences between the forecasts are mainly due to additional months of actual data that have been used in the DLS forecast. And so, for example, among individuals in the Healthy Babies Initiative, the recent enrollment has leveled off. And so the projected enrollment is reduced compared to the proposed budget in both fiscal 25 and 26. In fiscal 26, the forecast decreased from the prior year as, again, the disenrollments would be annualized, especially among the ACA expansion group. However, within the traditional Medicaid enrollment, specifically the family group, so parents and children, there is a difference between the two forecasts as the budget projects that enrollment will show marginal increase. And that's due to the assumption that growth rates seen before the pandemic will start up again. And so that will add more enrollees and have those groups increase slightly, versus the DLS forecast expects the family groups to continue declining slightly by 2% for each group in fiscal 26. And so turning to the general fund adequacy discussion on page 48, because the enrollment and forecasts in fiscal 25 were similar, the differences in projected spending was not due to enrollment in fiscal 25. Comparing the budget to the DLS forecast, the fiscal 25 working appropriation appeared to overstate healthcare utilization, especially among hospital inpatient services. And so DLS recommends reducing $100 million in general funds from the fiscal 25 proposed deficiency because of this difference in projected cost. For fiscal 26, there were more significant differences in enrollment. And as mentioned, this was mainly among the family groups and then the Healthy Babies Initiative. And as a result of those lower enrollment assumptions, DLS recommends reducing the allowance by $132 million across Medicaid and MCHIP. So that concludes the budget discussion. I'll touch briefly on personnel data. The Medical Care Programs Administration reported a high vacancy rate of over 16% as of December 31st. Of the 111 vacancies, 13 positions had been vacant for more than 2 years, and DLS recommends deleting funding for those long-term vacancies. So then moving on to the issues discussion that begins on page 49. This first issue has to do with Medicaid being a key driver of state fund spending growth. Besides K through 12 education, Medicaid is the biggest driver of state general fund spending. Recently, increased Medicaid spending has resulted from higher enrollment and healthcare utilization, in addition to expansions in eligibility and coverage. The proposed deficiencies in the budget project that more than $760 million more in general funds is needed to cover unexpected cost overruns in Medicaid and MCHIP, and that's across fiscal 24 and 25 combined. Despite Medicaid accounting for a large share of the structural shortfalls projected in the general fund forecast, the budget as introduced does not include many cost containment proposals aside from increasing the hospital deficit assessment. Due to the fiscal outlook and Medicaid's role in growing state spending, additional cost containment should be considered. One area to consider would be recent program expansions, like an upcoming expansion of the coverage of biomarker testing for conditions other than cancer. Exhibit 19 shows MDH's estimates for the annual cost to expand this coverage beginning in fiscal 26. The budget as introduced includes $8 million in general funds under the dedicated purpose account for this purpose, but MDH expected biomarker testing to cost $23 million in general funds in fiscal 26. And so DLS recommends delaying the expansion and reducing the $8 million. And as I said, it was in the dedicated purpose account, and so that recommended reduction shows up in the state reserve fund analysis. Other program expansions have been implemented through waiver amendments, such as MDH receiving federal approval to expand the Housing Support Assistance or ASIS program. For the pilot program, the state share was paid with local government contributions, and MDH would then claim the federal match for that local contribution. As of January 1st, 2025, MDH expanded this program with $5.4 million in state general funds. And so DLS recommends reducing the funds for the expanded program and instead returning to the pilot's program funding mechanism. Pages 51 and 52 list other recent Medicaid and MCHIP expansions and their projected costs. Given the state's budget challenges, the General Assembly should consider whether the most recent enhancements to Medicaid are affordable. And so then moving on to issue 2, this discusses potential federal impacts that could affect the Medicaid budget. And so as I just discussed, the changes to Medicaid funding are a driver of the structural shortfalls, but then there's also a lot of uncertainty at the federal level that could further exacerbate the state's budget challenges. And so because this topic was discussed in an early session briefing, I'll cover this rather briefly, but I did want to highlight that Exhibit 20 on page 54 lists some of the potential cost impacts of federal changes on Medicaid, and that this is updated to be based on the allowance. Medicaid and MCHIP are major sources of federal funds in the state budget, and that's mainly due to the 50% federal match that most Medicaid spending receives. I will note, though, that some groups receive an enhanced match. So the ACA expansion group receives 90% federal matching funds, and then the MCHIP group receives 65% matching funds. And so if either of these groups were to receive the 50% matching rate instead, then this would require the state to cover $992 million and $103 million respectively to continue covering that same group, but with the increased state share. Other things to consider is that federal support for certain eligibility groups could be prohibited or reduced. And so the exhibit shows the amount of federal funds projected in the allowance for certain groups or services that could lose that federal support. Potential work requirements for adults is also listed as a change, but with indeterminate state savings, as this would lead to projected enrollment decline. But I will note that any cost savings due to that enrollment change would be partially offset by administrative costs that would be needed to implement that kind of, to implement the work requirements. Another federal policy that has been considered previously is changing Medicaid from a reimbursement model to a block grant or a per capita cap. And so the state impact of this change would vary depending on how that's designed. But there has been analyses done in the past that says that it could potentially have significant impacts and significant reductions in federal funds for states in the long run. And so I'll just note that these federal changes are still very uncertain. But as I said to start, they could contribute to even higher state costs in Medicaid and MCHIP and further exacerbate the state budget challenges. And so then the final issue has to do with school-based health services. Medicaid is currently in the process of a two-phase plan to expand school-based health services beyond the services that are currently covered for students with IEPs. Phase 1 received federal approval and was implemented beginning on January 1st of this year, and that expands coverage to any Medicaid-eligible student receiving school-based behavioral health services from certified school psychologists and school social workers. A provision in the BRFA from last year allows funding for the Consortium on Coordinated Community Supports to use its blueprint funding on the Medicaid reimbursement for the state share of these services. Budget language limits that use to no more than $12 million. The fiscal 26 allowance provides that state share as general funds in BHA, and MDH is asked to provide an estimate for the annualized cost for this service expansion in fiscal 26. Pages 57 through 62 detail the recommended actions. Since I've presented most of them, I will only highlight a couple. Budget recommendations 2 and 12 and BRFA recommendation 4 all relate to issues that were discussed in the MDH overview. And recommendation 13 is for committee narrative to request continued quarterly reporting on enrollment trends. But otherwise, that concludes my presentation. I'm happy to answer any questions.
Thank you, Ms. Braun, for your thorough analysis and presentation. We always appreciate it. Before I ask if there are questions, I just need to take 30 seconds to acknowledge that we have Appropriations Committee royalty in the audience with the former chair, Maggie McIntosh, just hiding in the back over there. Even without my glasses, I saw you, ma'am. So thank you for joining us today and for all that you continue to do for Marylanders. Questions for Ms. Braun? I have one. Thank you for your early session briefing on the potential federal impact, the impact of federal actions on the entire landscape of the work that this subcommittee does, specifically as it relates to this budget. I know in many of our prior committee hearings, we have asked our agency partners, what do we know? What are we doing? What are the contingency plans? And that's in part because we're hearing from all of our constituents about it right now. And so I really appreciate your breakdown in page 52 of the different policy proposals and the impact on our state budget should these particular reductions in federal funding occur. I want to go back to page 48, though, where you talked a bit about the general fund adequacy and the projections that DLS has made alongside MDH and DBM of the potential enrollment that we have. And I know in prior years, we've sort of been able to use a lot of these great estimates to assess what the potential state budget impact could be so we could budget appropriately. How can we do that now with all of this uncertainty? There's so many different proposals floating about, including the ones that you have listed. And I would love to just get any information about, were the projections made with any of these proposals in mind? Can you share any information on that front?
Sure thing. So on the enrollment forecast, I don't believe either what's put into the proposed budget or the DLS, although MDH could speak to that more directly, but the DLS forecast does not account for these federal changes. I think that it is difficult to project at this time, as the issue kind of discussed. It's just so uncertain. No official announcements have been made, and so we really don't quite know what the effect would be, and so the forecast doesn't account for it. I will note that there could be some delays in it affecting Medicaid, and then there would be other benefits available, such as unemployment, and so we just don't know how many people might affect the Medicaid enrollment, but I will note that, yes, the forecast right now does not account for those effects as of now. So yeah, that would be something to keep paying attention to, as it is so uncertain.
Okay, that's really helpful. And so, I mean, that really relates to me, to a lot of the recommendations that DLS has around on page 48 related to reducing the deficiency appropriation and reducing further the FY26 allowance, because it is again, sort of pegging to a potential lower projected enrollment, but we're not quite certain yet whether that would actually pan out based on the federal actions. And so I agree. I think this is really important that we keep a really close eye on, and I'm confident that we will. So thank you. Okay, seeing no further questions from our subcommittee. Thank you, Ms. Braun. We'll now bring up Director Moran from our Medicaid Director. Welcome, and anyone from your team you'd like to bring. And you can begin when you're ready. Thank you.
Thank you, Chair Shetty, Vice Chair Jones, member of the committee. I just want to start by saying a couple things. One, it's a pleasure to work with each and every one of you. We take in the Medicaid agency your concerns of your constituents and the people that you represent very seriously. So continue to see us as a partner in that regard. I also want to welcome Nick Napolitano, who's our Director of Budget and Management. Our Chief Financial Officer is out with a nasty virus that I hope stays away from you. And then I also just want to thank all of the people who are seated here behind us as stakeholders and advocates. The Medicaid agency is also a partner to them from their varying levels of perspectives, importance within the healthcare ecosystem, and I just want to acknowledge their representation as an important part of this process as well. I also, my final thank you. Want to thank Ann and the DLS team. Some of you may or may not know, but we have a monthly budgeting process. We have a monthly convening with ourselves, the Department of Budget Management, Legislative Services. We meet in the interim, continuing to look at data, share workbooks, spreadsheets, et cetera. And Ann, I really appreciate you as a partner in that regard, specifically, and to the DLS team in those discernment of items. The last thing I'm going to do before we jump into the analysis is ask you for your grace and patience. Ann has provided me a lot to respond to, so we're going to move through those with thoughtful responses because I think that they deserve that. And so I'll just ask for your time and patience as we look to do that. First, obviously, want to thank all of you, DLS, the governor's team, and budget management for the insightful budget analysis and review. And I'm going to walk through each specific question for all of you. The first is the department should discuss the reasons for Maryland MCO's reporting declines as it relates to HEDIS performance compared to the nationals, as well as the methodology that MDH uses for determining moderate or major HEDIS performance issues. And the purpose of the HEDIS performance monitoring policy, which is to set a standard of quality incentives to promote better health outcomes for Marylanders to meet. Those are outlined in our MCO contracts on an annual basis. The policies look at a multitude of things. They look at quality of care metrics. They also look at systems monitoring and review. They look at network adequacy issues, ensuring that MCOs have an adequate base of providers to serve participants, and performance improvement projects and issues. Overall, we would note that 3-year trends indicate incremental improvements across our MCOs. However, each MCO has certainly demonstrated room for performance improvement in individual results. This is a credit to Secretary Herrera-Scott, who really values the importance of quality in our managed care program. And we have made changes to ensure that we increase the accountability and requirements as it relates to the service that Medicaid managed care recipients receive through our MCOs. That has been dictated in our 2025 contracts, as well as taking a close look and revising all of our policies to ensure that we're increasing the rigor of which we hold our MCOs in the state accountable for serving our members. Next, the department should provide the current status of health equity accreditation for each MCO and the time frame for each to complete. I'll note that 5 MCOs, it's a requirement in the 25 calendar year contract that all 9 MCOs have health equity accreditation. What that means is it gives everybody a standard, a floor, a benchmark to work towards in terms of best practices as it relates to health equity and reducing health disparities in their programs. The 5 that have already achieved that include Aetna, CareFirst, Kaiser, United Healthcare, and WellPoint. I'll also note that for MCOs that have not yet achieved, we have a check-in with a comprehensive check-in due by the middle of the year to ensure that they achieve that accreditation by the end of 2025. The department should clarify if the current population health incentive improvement program already aligns with what is projected to be as part of the AHEAD model, and if not, discuss the new measures that the department will select in the 26 contract. The first is the population health measures do overlap with some of the quality measures that are aligned with primary care AHEAD and the overall work related to AHEAD. I will note that alignment is the name of the game in terms of we look at the healthcare ecosystem, payers, providers, et cetera, in terms of what we are evaluating to ensure that we're really tracking accurately on population health improvement. And I'll also note that we likely do expect changes in the population health incentive program for MCOs in the future to ensure that there's full alignment with that particular work. Next recommendation from DLS is the reduction of $9.2 million in total funds from the deficiency to account for the balance of unallocated funds for calendar year 2023 MCO incentives. Given the fiscal outlook, DLS also recommends reducing $18 million in fiscal year 26 of the 0.25% of cap rates. The department respectfully disagrees with this recommendation. Currently in fiscal year 26 in the future, we will pay out performance incentives from the past. So we've already reflected those as part of contracts that the managed care organizations have already signed with the department, including the ability to have additional funding support for improvements in health equity that we've already talked about in terms of accreditation. We will note in terms of our calculations that we will need $25 million to do that. And therefore, in fiscal year 26, the department would recommend only an $11 million reduction in total funds, and for 2025, the current fiscal year that we're in, a $9.2 million. I'll also note that in coordination with the Department of Budget and Management, we plan to reflect this in an upcoming supplemental budget process. The next question is providing a baseline membership for each MCO across the 6 jurisdictions that receive the health equity incentive, and to discuss whether the department has taken action or is considering the zip code specific level that's provided from the Governor's Enough program. We've provided, I won't read it to you, but we've provided the 6 counties that we look at in terms of socioeconomic disadvantage that helps us form the basis of our health equity incentive calculations. And we would consider taking the recommendation of the methodology in alignment with the Enough program under some of the constraints that we have with rate setting in the MCO process. Department should provide an update on the MHB audit finding related to Medicaid application processing, including whether Medicaid applicants that were found to have incomes higher than the eligibility threshold have been disenrolled as appropriate. I'll just say that the department, in partnership with the Maryland Health Benefit Exchange, which for this specific audit finding supports our work in Medicaid eligibility. We just received this report from the Office of OLA at the end of January, and we provided responses that respectfully disagree with the audit finding from the OLA auditors, as well as the need for any additional corrective actions. We note there that we feel as if we are following federal regulations, that we can accept no income attestations at the time of application. Those are acceptable based on federal guidelines. The most common example I would provide there is if you're an individual who experienced loss of employment, you would attest that then you have no income, and the federal regulations deem that to be appropriate. Is it important? DLS recommends reducing the proposed deficiency appropriation to account for the 2021 and 2022 risk corridor recoveries from the MCOs. We concur with that recommendation. And MDH, we're going to be working with the Department of Budget and Management to ensure that those anticipated savings are reflected as part of a supplemental budget process, and also to address projected budget shortfalls within the Developmental Disabilities Administration. The next one is around correction of some technical errors. We'll clean up our spelling, no problem. We'll concur with that recommendation. The next is recommending deletion of $16 million in general funds for the new primary care program fund. In consultation with the Department of Budget Management, we respectfully disagree with this recommendation. We would note that the budget bill mistakenly admitted a contingent reduction to replace the $16 million in general funds with a source of special funds, and we will reflect that in an upcoming supplemental budget. DLS recommends to keep an eye on our Maryland primary care program under AHEAD. We concur with providing this committee a report and to be fully transparent with the exciting program of primary care investment that we'll be making across the state. DLS recommends rejecting a BRFA provision so that funding for entitlement programs within MDH continue to be restricted for their budgeting purpose, allowing for certain transfers as specified in budget language. DLS recommends adding budget bill language for fiscal year 26 restricting funds for Medicaid and MCHIP reimbursements to that purpose. I will note here, and this is one that's very important for us, we would respectfully disagree with the DLS recommendation, and we noted in the Senate on Friday that we would be open to working with Department of Legislative Services on making some of this activity contingent upon a report that the department would provide. I only say that because some of these particular restrictions do place the agency with undue stress in our budgeting process, impeding our ability to address internal shortfalls, also ensuring that we're able to effectively pay providers. And we would ensure that we would have this particular flexibility as introduced in the BRFA moving forward. And to your comments, Chair Shetty, flexibility is now even more important as certain budget pressures will disallow any cushion across the administrations for changes that could happen in enrollment, utilization, and other drivers. And again, if it could be a contingent upon report language, we would welcome those particular, that language. DLS recommends amending the BRFA provision to increase the authorized transfer of $14 million from the Maternal Child Health Program. I'll note that the department has been supportive of Senate Bill 213 and House Bill 170, which is a sunset extension of maternal and child health funds, extending beyond the sunset date that's currently in December. The Maternal Child Health Improvement Program provides important Medicaid benefits to address severe maternal mortality, and it is a main priority for our department. Those monies receive eligible federal matching dollars and support home visiting services, doula services, case management interventions to support prenatal and postpartum care. And the proposed increase in the recommended transfer would impede the department to provide services beyond 2026, so for fiscal year 2027. But we would say that the department would allow and supports the additional transfer if that particular piece of legislation is enacted. DLS recommends deleting $18.2 million from the Health Home Program. You're going to see this in the Behavioral Health Administration analysis as well, but the department respectfully disagrees with that recommendation to reduce funding. The accounting for this item has shifted amongst programs within the department, and the full funding amount for the appropriation should be accounted in the legislative appropriation. The department should provide a status update on Medicaid transformation projects as it relates to information technology. There are 14 of those that are on varying portions of their life cycle. I'm not going to read the status on all 14, but they are there for your reading as well. And then we've also provided what has been spent to date for each of those projects, as well as what is planned to be spent for those throughout the course of fiscal year 25. And if any of you have any questions, I'm happy to take those. The DLS recommends adding a provision of the BRFA to expand allowable uses for the Senior Prescription Drug Assistance Program in 26 and in future years. The department notes that in consultation with the Department of Budget and Management, we respectfully disagree with that recommendation. The Senior Prescription Drug Assistance Program fund source was included in error in the 26 statewide account, and we plan to correct that in the legislative appropriation upcoming. Due to the fiscal outlook, I'm going to move now to questions, if you will, that relate specifically to some of the recommendations on cost containment to Medicaid's budget and the department's stance on each of those. Due to the fiscal outlook, DLS recommends $12.2 million in the enhancement for physician E&M rates in fiscal year 26. Department respectfully disagrees with that. You'll remember from last year, physicians were the only Medicaid provider in 25 to receive a cut, while other providers received a 3% rate increase, including a significant increase in hospital rates as established through the HSCRC. The $12.2 million that's offered in the budget ensures that we restore that particular cut and maintain the physician fee schedule from fiscal year 24. I will also tell the committee that this particular item is of grave importance as we think around our work of building out primary care infrastructure and investment in the state and having an adequate support of specialty physicians to support referral networks to support Medicaid participants. DLS recommends reducing $90 million in total funds to lower MCO rates to the bottom of the rate range. The department respectfully disagrees. We'll also note here that the department has updated expected acuity adjustments that will need to be made based on data that we have through December 31st of the population that we have. Our actuary teams are estimating that $165 million is needed in total funds rather than what was originally thought of $124 million. That's just what we have seen as what the rest of the country has, an increased clinical acuity of patients. We would also note that if rates are set at the very bottom of the rate range, about $100 million would be needed for that adjustment. That means that the recommendation should only be about $25 million. However, we would also note that there are a lot of other puts and takes in the MCO rate setting process that we will need to account for, including our expectation that there'll be increase to hospital rates later on for fiscal year 26 that we will need to account for. Also, we will note that post the redetermination process, our MCOs are managing significant changes in acuity, higher acuity population that's currently within the population, and reducing rates at this particular level would mean that some MCOs would lose money. The current calendar year 2025 rates of the rate that the department has set accounts for collectively amongst all 9 about a 1.25% profit margin. Due to there being no mandate of additional rate increases, there's a recommendation here to accept the additional 1% increase that was introduced as part of the governor's budget. The department acknowledges that recommendation. The next is a recommendation to reduce home and community-based services provider rates by 2% effective July 1st, 2025. The department respectfully disagrees with that recommendation to reduce home and community-based service provider rates. We would also note that there's a process that we'll need to go through at the federal level to actually get that reviewed. What the federal government, based on new federal regulations, will look at is sort of looking to ensure that we have adequacy in terms of provider networks and that no rate reductions will impact that. So they must review and approve that. I will also note that that proposed reduction in the home and community-based services space, home care workers, medical daycare, et cetera, does not support in the weight initiatives, which our goal in reduction is to reduce by 50% by 2028. I will note that in every report that the department has put forward, rate sufficiency in that regard is paramount to ensure that we have adequate providers in that space to serve additional participants that we need to move off the wait list and to receive services. Due to budget overstating healthcare utilization, DLS recommends reducing the 2025 deficiency appropriation by $100 million in general funds. The department respectfully disagrees with that recommendation. We also wish to work with the Department of Legislative Services to sync up on data and to understand more detail around this particular analysis. Because we as an administration continue to see strong utilization trends and increased clinical acuity across the patient population that we serve. We will also note that we provided a chart here which provides and shows on our end that we're actually seeing increases in utilization, not reductions, but happy to talk with DLS for further data comparisons. As a result of the lower projected enrollment in fiscal year 26, DLS recommends reducing the fiscal year 26 allowance for Medicaid by $90 million total funds and about $42.8 total funds. The department respectfully disagrees that enrollment projections should be reduced. I'll note that through the consensus budgeting process that we've talked about at this forum, we've provided a significant amount level of transparency on a monthly basis related to our refined assumptions for enrollment. The department strongly affirms those enrollment trends that we have outlined for both 25 and 26. We've also provided here of how close our enrollment projections year to date are and have been. And further, Chair Shetty, as you just mentioned, it's important to note that these projections were solidified without a greater appreciation of what is now happening at the federal level. And so as Maryland obviously is a state that's disproportionately impacted by a higher number of federal workers as well as government contractors, impacts to Maryland's workforce by current and future decisions at the federal level will undoubtedly impact Medicaid enrollment, and it is our opinion that this moment is too full of risk to endorse adjusting enrollment to achieve budgetary savings in the state. The only enrollment projection of which that we do believe we can concur relates to Healthy Babies initiatives. The actual average enrollment that we're seeing in the later portions of 2024 is around 8,800 folks. We would, I think currently the projections say that somewhere there were around 9,250 built into the budget. We're saying that we could come down to what we were seeing at the portion of 2024 of about 8,800 for budgetary numbers. And we'll be working on a supplemental budget request to reflect that as administration. DLS recommends deleting positions, 13 long-term vacant positions that have remained unfilled for more than 2 years. The department respectfully disagrees with that recommendation to delete vacancy positions. While I understand and I completely respect the ability to recognize the long-term vacancies of these roles, the department has transitioned to new leadership in the realm of eligibility services and long-term services and support, and it is the highest priority from my office to fill those vacant positions. In fact, 5 of the 13 that are identified are currently pending a commitment letter to go out the door from Human Resources to fill those positions. 3 are posted on our job website, and 5 are being transferred to the Department of Corrections and Public Safety to support our work around Medicaid coverage for individuals leaving incarceration. Those positions are looking to be retooled to support individuals back into the community to provide them with support related to case management services, prescription drugs, and navigating them to necessary community supports for individuals leaving incarceration. DLS recommends adding a provision to the BRFA of delaying biomarker expansion. Department respectfully disagrees with that recommendation. This has been a priority of the Legislative Black Caucus in 2023 that passed both chambers with near unanimous votes. The $8 million that's proposed as part of the governor's allowance in the dedicated purposes account will give us the ability to focus on additional testing to have the greatest impact on eliminating disparities and improving health outcomes. The department, DLS recommends reducing the $10.8 million in total funds for the Assistance in Community Integration Services program and returning the pilot program to local funding. The department respectfully disagrees. The local spending to support the Assistance in Community Integration in Baltimore City, as an example, was funded by hospitals. The hospitals have stopped providing that funding support because the governor's budget included funding for this particular fiscal year. I want to remind you of the importance of that program. That provides intensive case management supports for individuals experiencing housing insecurity. And it is one of the programs that has been well studied by the Hilltop Institute by having positive health outcomes, but also aligning with our goals as a state under a head to reduce healthcare utilization and to ensure that people have the necessary resources and supports that they need within the community. And I would note there that we just received that waiver approval to expand that program from Baltimore City, Cecil County, Montgomery County, Prince George's County, where it currently operates. We just received approval for that to go statewide, and that was already in the governor's budget, and plans are fully underway to expand that particular work. This recommendation would eliminate even the pilot jurisdictions that are listed here of those 4. The next is, given the state's budget challenges and expected federal reductions in Medicaid funding, we're asked to, the General Assembly, should carefully consider whether some of the most recent expansions over the course of the past 2 or 3 years in Medicaid are affordable. We would just note here, obviously that's a recommendation not to the department, but the General Assembly, but that we advise that any action at the state or federal level would need specific actions to happen in order to terminate benefits, which is what we are talking about here. We can't simply flip on and off that switch. That's a 6 to 12-month process that we have to go through. All of these are within state statute, as an example. All of these have a federal authority attached to it. In the same way that we as a Medicaid agency need to go provide approval for the authority, we also need to get the authority to unwind benefits. So there is a process related to that. And we would just respectfully request the opportunity to be partners with you as you are in your own discernment around potential programmatic changes or cuts that were listed here from DLS's recommendation. And then lastly, the department should provide an estimate for the annualized cost to continue phase 1 expansion of school-based health services. Starting January 1st, 2025, any Medicaid kid across the country, 3 and 8 of children in the state are covered by Medicaid, can now receive support, or we're working with local jurisdictions, local school jurisdictions, can receive services that are Medicaid reimbursed from a school psychologist and social worker. We have been working very closely with local jurisdictions to roll out this particular program. Particularly important, particularly for me, because the reason I sit here at the table is because I had a behavioral health provider in schools to help me in my own journey. And I think about the importance of this. That funding is reflected in BHA's budget that you will hear about for future sustainability after working with appropriations and budget and tax last year on a longer-term solution for that program. I appreciate your patience. Thank you so much. I will just close by saying, happy to answer any questions you have, but also I just want to give a huge shout out to the 700 team at Maryland Medicaid that works day in and day out to serve an incredibly important population of 1.5, almost 1.6 million Marylanders in this state. I am in awe of their service daily, and it is a credit to them of the significant amount of work that we have completed to ensure that we have a responsive, efficient Medicaid agency here in Maryland. Thank you.
Thank you. That was wonderful. Always great to hear an update on some of the work that we've done in prior years and see the impact continue. It's really great. I will recognize our vice chair for questions now.
Thank you so much, Chair. Thank you, Mr. Moran. Truly appreciate it. And if we could continue a little bit on the conversation regarding our federal exposure, especially here. On page 3, I was wondering if you could talk a little bit about the federal uncertainty. In every single hearing, I bring up contingency plans with agencies, how possibly we could prepare for the unknown. And, you know, Medicaid is at significant risk. Federal participation for most costs, some 65 to 90% matching rates. Do you want to talk a little bit about the potential impacts of federal changes to Medicaid?
Yes. What a moment for the Medicaid program here and then across the country. So I will say we, just like the Department of Legislative Services has, we have done sort of an analysis of some of the policy proposals, right, that we know about or that are talked about publicly. Some of those, namely, that I will mention is, I think, the biggest win from a federal risk in terms of cost perspective that you've heard about and you've alluded to is that any change in the calculation related to state match versus federal match. There are a number of ways of which that could change that we are following in the House and Senate. I think the biggest one that we have our eyes on, just like DLS did in their particular analysis, is that because we are an Affordable Care Act expansion state that moved to go up to 138% of the federal poverty level for adults, for about 375,000, 380,000 Marylanders, we receive 90% of federal match for those individuals. And there is talk, right? One of the policy proposals is changing that match to be more of a state participation in that regard. The other ones that I would note would be around more frequent eligibility checks or imposition of work requirements. You know, we know from our other state colleagues that have work requirements, for example, those equate to a significant amount of administrative burden on the agency in terms of those particular things. So we're looking at that. We're also keeping a pulse eye on if they were to go to some kind of block or per capita spending. Right. It's very hard to model out some of those things until you have specifics related to those, but we certainly have our eyes all over it. We are connected at both the Association and Medicaid Directors perspective level to see which path the House and the Senate are taking. It looks like they may be taking diversion paths on this particular regard, but we have our pulse all over it, Vice Chair Jones.
Thank you so much. I commend your work. I know how scary this is for so many. I don't go a day without being stopped at Grouse or walking my golden retriever or anywhere where a constituent is not pulling upon me the same way they're pulling upon everyone in this house for fear. So thank you so much, and I look forward to continuing to be a partner with you. Thank you.
Appreciate you so much. Thanks.
Okay, thank you so much, Madam Vice Chair. Recognizing Delegate Heinbaugh.
Thank you, Madam Chair. Thanks for your thorough response to the DLS analysis. We've heard a lot of talk about potentially the federal government going to a block grant type of funding. What are the implications of that for you? Is that more administrative work, or would that, maybe it's premature to ask, but would those block grants come to specific programs or a larger chunk of money, or?
We have a lot of the same questions that you have, because what is absent in some of those current discussions are around sort of like, what are the funding calculations of how those things would be set up? How would you trigger that? How would you allocate that among states? What methodology are you going to use? So those are all questions we have. We don't have a lot of things to react to. I would say, I think that there's more conversation, which is why I started with it, on, if you will, the simpler way of changing or receiving federal reductions, which seems to be the goal of that the legislative bodies are taking, is to look at the state contribution versus the federal contributions. And that is where we have done more modeling. I mean, I talked about the 90 to 10 contributions, but for children in the Maryland Children's Health Program, we get a 2-to-1 match. For some of our information technology and design systems, we get a 90-10 match. All of those, right, I think are items that could easily be changed, that would change the federal calculus on the amount of money that they would need, but then the amount of money that the state would need to ensure that those benefits with no other changes are preserved, if you will. And on the per capita and blocks, it's around a measure of coming up with more information that's needed that we don't have a lot to react to at the time.
So just one quick follow-up. So would the match stay the same then for the various programs if you get funding in block grant, or could the match change versus?
I mean, they would set sort of a methodology that would be different than what the state share would be right now. So it would be a different sort of what mechanism of financing related to that particular proposal. But again, I would just say that the other way the more simpler way, if you will, to change the calculus is to really change the state and federal share, because the block and per capita would get into other kind of methodology and numbers to use.
Thank you, Madam Chair.
Thank you. Delegate McCaskill.
Thank you, Madam Chair. So I just want to thank you and let you know that you were on my mind all weekend. As I went through this report, I have all these question marks, like, ask Ryan Moran. This is for Ryan Moran. And so we'll come back to why you were on my mind so much, and it is around biomarkers, so I am glad that you mentioned it. But I do want to go back to page 13, around your response to the DLS question around reporting declines for the HEDIS performance compared to the national mean?
Yes.
Perfect. And so in reading your response to their question, I see that you discuss what penalty and enforcement options there may be for the various issues, minor, moderate, major issues. But can you elaborate on the actual process of determining when and what penalties are actually applied?
Yes, so all of these particular requirements are outlined in our contracts with managed cares year over year. So they enter, if you will, knowing the rules, right, of the game in terms of how potential that they would apply. And then our sanctions policy outlines that if you're out of compliance with any of these, or if we find our reviews to be in whatever way that we can take these particular steps, so that those are outlined. I will say that our responses also talk about the ability to have more rigor and accountability in the future. As an example, we can go through this process, which is a collection of this particular work in terms of our performance monitoring, looking at quality measures, right? It's a methodology and a formula that we use, but looking at quality measures, looking at provider adequacy, looking at performance improvement plans and results from the managed care organizations. That gives us, once we put it into our methodology, whether it's a major problem, minor problem, or moderate problem. One of the ways that we do that is it looks at some of these issues, whether they're year-over-year problems. So that gives us a sense of their systemic problems that would help us to achieve those ratings. Once we form that, then we are aided by our sanctions policy. And in the future, what we have outlined here is the Population Health Incentive Program will be used as a gate, an additional gate of incentive to try to drive improvement in the program.
Thank you, Madam Chair. One more question that I'm burning to ask. Okay, and this may be further discussed at a later time, and I do understand streamlining and efficiency, but I'm looking specifically at pages 49 and 50 when we speak about the estimated cost for biomarkers.
Yes.
Perfect. So, two specific questions. You mentioned that this is a priority for the Legislative Black Caucus, and I'm looking at the different conditions that hit our community quite rampant. And so how do we know how well these biomarker testing is being utilized?
So I'll note, and we can provide you the actual data. So the first part of that piece of legislation from, I want to say 2023, was the first phase was biomarkers related to cancer. And we did launch that, and we can provide you the utilization. I don't know that off the top of my head, but we have about 6 to a year months worth of claims that we can get you related to that. I think what is outlined here is sort of a mix of two things that would allow us in these other areas, right, beyond cancer or additional expanding of cancer, kidney, behavioral health, autoimmune, cardiovascular, infectious disease, what you see here, be a couple of things if additional funding was provided. One, we could look across the biomarker coverage that we have and discern and say, are there additional coverage that should be added in each of these particular areas? And then two, as you are well aware, this is an rapidly evolving space, and we do expect there to be some increased utilization of biomarker testing, particularly if you were to expand it beyond cancer, people find out, and understand that the benefit is available in the Medicaid program. And some of these estimates that we've originally outlined build in some increased utilization related to that, just based on what's happening and it being an evolving field of science.
Last question, and then I will be following up. I'm thinking about how these biomarkers shall be covered with the private provider on the private side. And so maybe a further conversation, we need to look at what role those providers are willing to take for these biomarker testing, because we don't want to continuously cut these services or delay these services for these communities who desperately, I look at cardiovascular, if we look at the chart, you all have placed it at a high marking in the blue, and that's one of the things that kill the African American community at a high rate here in the United States. And so I want us to make sure that we're having some further conversation. I appreciate your, your response to DLS as far as perhaps delaying it, but maybe we should also be looking at the private providers and how they can also play a role in making sure that these testing, these tests are covered. Thank you.
Thank you, Delegate.
Thank you, Delegate. I think as we're thinking about these items, I think it's important to recognize as well the purpose of the legislation, right, was to drive clinical decision-making so that it's evidence-based and patients aren't run through the ringer of having, different, medical treatments offered to them that are not necessarily going to positively impact their outcome. And since we're keenly interested in seeing better health outcomes for our patients and lowering costs while we do it, this seems like a really good opportunity to really focus in on this. So thank you, Delegate, for the question. I see Delegate Ruff.
Thank you, Madam Chair. And I agree with you. Thank you, Delegate, for standing up for our Black Caucus priority. And, I couldn't so confidently do that with the juicy juice at my side. So that's my friend, so I could do that. I figured I'd lighten the room up a little bit, talking about such difficult budget issues. So thanks for your indulgence, Madam Chair. So I have a couple of questions around a couple of different topics. A couple of the DLS operating budget recommendations around personnel, and then also going back to the MCO health equity incentive calculation. So I'll start there. If we look at that, considering that you've indicated that the department could consider using the Enough program neighborhood eligibility metrics, in your view, what are the pros and cons of adopting those metrics, and what are the major differences between the calculation metrics that you guys use now and the Enough structure?
Yeah.
Go right ahead.
Yeah, thank you, Delegate. What I would say is what we are going to do is related to this recommendation, we're going to look at the particular zip codes that are prioritized related to Enough and overlap how our methodology for the health equity incentive is calculated. I expect them to be pretty close in alignment with each other. Some of the other considerations and just implementing that is related to the way that we do rate setting, right, which isn't at a zip code or a census tract level. We look at it from a county-based perspective and with our work of actuaries there. So we have to figure out those operationals, but we're going to do that analysis and understand what the difference, if there is any there, in the way that we structure the current program we have.
Okay, but the fact that the fact that the health choice capitation rate structure is based on counties isn't going to be an obstacle to that kind of comparative analysis.
I don't have the full confidence of that, but I think once we overlap and look at the particular zip codes for Enough and the counties that are a part of how we calculate the health equity incentive, I think we'll know that answer. We actually kick off this week our calendar year 2026 rate setting process with the managed care organization. So this is one of the things that we're going to be looking at as part of the issues list for that process.
I'd be pretty interested in getting a follow-up on that, and to see.
Happy to do that.
Yeah, to see if it seems likely that you could move into that calculation structure. Going back to personnel, you noted on page 48. It was noted in the DLS analysis on page 48 about the 111 vacancies, and you did a bang-up job of anticipating our questions about the 13 pins or positions that DLS had recommended defunding. So I get that there are some major plans in the works for those positions. I'm just wondering, did that initiative take place between the end of last year and now, or how long has that stuff been going on? And then can you comment on the additional 50, the plans for those and filling those and making sure that we're being diligent about those funds?
Yes, so I think it's been no secret or question that when the change of administrations happened, we've had a significant amount of staffing vacancies across the agencies. There are really 3 areas within the Medicaid program that are high priority that we've been working on, that I've made priority right for the last 18 months in this particular capacity. That is the area of eligibility services that's the area of long-term services and supports, and that's the area of Medicaid Office of Finance. That's not to say that there aren't vacancies otherwhere in the department, but those are the three areas that are top priority. So from the long-term services and supports department, we have new leadership within that particular area. That had an enormously high rate of vacancy post-pandemic, just as the long-term services and support industry experienced that shock, if you will, from COVID-19. The agency was not immune to that as well. We've done extraordinary work to, as we've noted in here, of those particular plans. And then the final stretch of some of these long-term vacancies that we were already in process, if you will, to fill those positions. In the area of eligibility services, our eligibility team is an incredible group of folks that have been under enormous amount of tax and stress related to the redetermination and unwinding period. So not only do we have long-term vacancies there, but we, the recruitment and retention as we've started the redetermination process. We have a new leadership in eligibility services. We have a plan related to the vacancies that exist in eligibility determination division unit. I know that a number of questions that may come through your offices related to questions around someone's eligibility stem from that unit. It's of high priority and focus, and that's where these other positions come in. Finance, some of these positions also include net new positions that were awarded last year in the budget that we're just starting the process for recruitment for. But I will tell you that it remains a priority for us to continue to fill vacant positions with particular focus when we look at, who are my highest variable areas in those particular areas.
Can I continue, or do you want to? Okay.
May I make one other comment, too, on the other positions, if you don't mind?
Absolutely.
I'll just also note that some of the 5 long-term vacancy positions were actually 5 positions that were in our eligibility services division unit. And they were designed with corrections and public safety a few years ago to really think about how those individuals could support individuals leaving incarceration. And those positions were incredibly hard during COVID to recruit for. So when the opportunity came for the 1115 waiver to apply for CMS and to receive approval that we would officially begin that particular work, working on an operational and implementation plan with corrections and public safety, it's much more of a plausible avenue and opportunity for those individuals to work with our corrections and public safety individuals. And we're going to reflect that in an upcoming supplemental budget, that those positions, if you will, go back to corrections and public safety with the advent of this new work. Just want to make sure that note.
Yeah, I caught that on your presentation, and it made me think about whether that funding will be used in some way to somehow push forward this idea of a women's pre-release center. But that's not your problem. So the last thing I want to touch on is 3 of the DLS operating budget recommendations, number 3, number 4, and number 7. As to 3, the $18 million reduction recommendation, can you talk about how that money is currently allocated for the Population Health Incentive Program?
Yeah, so the Population Health Incentive Program looks at a key set of measures that are important to the state health plans. So I'll name some, diabetes as an example, some metrics around opioid substance use, if you will. Those are metrics that we use to say to the managed care organizations in order to drive improvement. And actually, the department switched from this a few years ago, but we reserve a portion of managed care organization rates, or it's a percentage of those particular rates. And then there are the methodology that this uses, there are sort of 2 gates, one for achieving a certain level of metrics and one for improvement overall. And so what we're finding, and which is what we have recommended in terms of the DLS, is that there is opportunity based on what we have seen related to MCO performance of that recommendation of around 0.25%, but we have provided the actual calculation and number that is needed to fund those particular programs.
As to number 4, you touched on this in your presentation, and I just wanted to make sure I heard you right, that you said 100 million, oh, excuse me, as to number 4. And it's just so for the record, so everybody's following along, talking about the recommendation to reduce funding for Medicaid provider reimbursements to lower rates for managed care organizations to the bottom of the actuarial sound range. You said that $100 million would be needed for that adjustment. Did I follow that correctly?
So what is needed for that adjustment is that, so this is a very volatile time in managed care rate setting, only because we've been dealing with the unwinding of the public health emergency. So there's been significant shifts in enrollment. There are significant shifts in clinical acuity of patients that remain as part of the MCO plans. The rate setting process over the past for 24 and 25 does consider what we call a public health emergency sort of acuity adjustment. So we look to ensure that the rates, the simple way to say it is we look to make sure that the rates are actuarial sound. And actuarial soundness is just a financial term that looks as, is it sufficient to cover the costs, and is it based on a founded methodology and capitation rate setting that's followed, that our actuaries follow, the department follows, and then that the CMS ultimately has to approve. So we would actually advise and respectfully disagree with that particular recommendation, only because there's some volatility as it relates to the managed care rate setting process as we are wrestling with an increased acuity population, changes in enrollment, and we also to expect that there actually will be some increases that will be needed to MCO rates, and so it's best to preserve that funding. We don't have a choice if we get to a place where we have to preserve rates for MCOs at an actuarial sound level. So we would just advise and respectfully disagree with any cuts made there.
What would you predict would be the outcome if the Medicaid provider and reimbursements are lowered as the recommendation suggests?
Yeah, so currently what we have outlined is that where the department has set the rates, and again, there are other things that would particularly may change, increase rates in the future. For all collective of the 9s, it looks at an aggregate profit range around 1.25%. If you were to move to the bottom, you're talking about, at that point, MCOs losing money, and then there are other questions that come into play around and support that the department needs from our managed care organizations on investing in health equity incentives, investing in population health, investing in a Medicaid primary care investment program. These are all demands and requests that we are asking for our managed care organizations to support us for in that regard.
You're super sharp. Appreciate you.
Thank you.
Thank you very much.
Thank you, Delegate. Thank you, Director Moran. Vice Chair.
Thank you so much, Chair. Mr. Moran, I want to ask a question. Appendix 3 through 16 of the analysis really covers, and I'm named appropriately, Major Information Technology Development Project. It's major. It's huge. It's 13 modular systems or components that are being changed, right? So I'm curious, with private insurance like Change Health, it was this time last year approximately, having a major data breach, and with completion dates here anywhere from 2026 through 2030, excuse me. How are we making sure that privacy and security of all of this data is being handled at the right level?
Such an excellent question. With Change Healthcare, as you aptly noted, and just the where we find ourselves from a healthcare information technology. So I appreciate the question. The department has a Chief Information Security Officer that looks at monitoring our protocols related to security with all of our information technology systems. We also embed in each of these, most of these, all of these, right, that are a part of these appendix, do involve some type of a RFP that vendors would respond to. related to support it. So for the Behavioral Health Administrative Services Organization, as example, we currently switch, that is now Carillon. We require stringent security standards that meet security best practices that security analysts beyond me know about, but we ensure that they are included there as part of the state. And so all of those go through that particular type of review, both from an RFP perspective, but then from each of our contract monitors on each of these process, we're reviewing those security standards as well. And I just appreciate the risk that you have outlined because it is, obviously present in our work. I will also note that some of the increased accountability requirements also for our managed care organizations. So we have in the 2025 contracts now have dedicated require C-suite positions as well as director and manager level positions. We require a chief information officer in each of our 9 MCOs, and that individual, needs to work appropriately with each of the managed care organizations to ensure the safety of their systems as well and monitoring that for us as an agency. So we're taking a close look at ensuring of how, every way possible that information technology becomes, the foundation of everything we go into.
So thank you so much for your answer. And so the C-suite employees, as far as CTOs are concerned, they are not subcontractors, but they are hires.
Leadership positions, hires of the managed care organizations, yes.
Okay, thank you so much.
Thank you.
Thank you, Madam Vice Chair. I see another question from Delegate Heimbach. Go right ahead.
This is one, it's more of curiosity for me than anything else, I think. But on, let's see, Appendix 3 on page 70, the last bullet, which is actually on page 71, this is under the long-term services and supports tracking system. It says that there's a 99.3% federal matching rate. And I read that I guess this program has been evolving over time. That seems like an unusually high matching rate. Has that rate been like that historically, or is that something recent, or?
Well, I appreciate your attention to detail, and that does, and so I'm happy to take it and ensure that we have it for the record.
Like I said, it's a small point.
Yeah, yes.
Yeah, thank you.
We love your attention to detail too, Delegate. Thank you. So I just have, I'm going to just flag a couple questions. I'm going to follow up with your team by email. And it's related to the Object Fund Report, Appendix 18. So we're going to follow up by email, but I have specific questions we're going to send related to line 2, technical and special fees, line 9, supplies and materials, and then the equipment noted in line 10. Each of these components have a pretty substantial increase, so we just kind of want to understand a little bit more about that. We'll follow up by email, okay? And then the last question I have is related to medical day. So on page 27 of the analysis by DLS, it notes that you all are planning to revert $500,000 that was provided as part of the FY25 budget for medical day service providers. So this comes on top of additional recommendations of potential cuts to these same providers. And so I'm just curious if you can share a little bit more. I think the analysis says that you all were uncertain about the legislative intent. Can you just anything more you can share? Maybe we can take a conversation offline to get to this, because this is, a good bit of money you'd be reverting back that was appropriated for this purpose.
Happy to talk with your office directly, Chair Shetty. What I would say, and you have acknowledged this, is but for all home and community-based services provider, which inclusive of medical day, obviously we are strongly in disagreement with the 2% cut across the board, but happy to follow up on that specific item.
Okay, great. Thank you. Seeing no further questions from our subcommittee, great job. That was a very thorough round of Q&A and presentation. Thank you so much. We will now move to our public advocate testimony, and Director Moran, just as usual in our subcommittee, you know our drill. We love to have you stick around to hear what our friends here have to say. So thank you for making time to do that today. I'm going to call up individuals in the order in which they're listed on my sheet. We'll do 4 at a time. So the first person I have listed is Kevin Lindemood with Healthcare for the Homeless. Second is Joseph Wynn with Maryland Managed Care Organization Association. Third is Nicole Grainer with the Community Behavioral Health Association. And fourth is Alistair Chang with Fabric Health. Okay, great. And you can begin when you're ready. We can start with you, yeah.
Excellent. Chair Shetty, Vice Chair Jones, members of the committee, thank you for the opportunity to testify today. I'm Kevin Lindemood with Healthcare for the Homeless. We are Maryland's leading provider of integrated health services and supportive housing for men, women, and children experiencing homelessness, serving about 11,000 different people in Baltimore City and Baltimore County. We're also the service provider for 300 of the state's 600, little more than 600 waiver slots. We are here in extremely strong support of Deputy Secretary Moran and the Medicaid budget. I also served on the Medicaid Advisory Committee for a number of years, and I don't think I've often seen this much interest in Medicaid policy. It's great to see. We're also, with all due respect to DLS and the very difficult job it must do, we were frankly alarmed by the suggestion that the state fully eliminate the Assistance in Community Integration Services Medicaid supportive housing waiver. You may recall we were here just last year celebrating that this 6-year-long pilot, the effectiveness of which had been proven, was now scheduled to be expanded statewide. And as you heard, that authorization has now been achieved. It is hard to overstate the vulnerability of the individuals we are serving in this program that must actually pass a vulnerability test to be selected as the most likely to die on the streets. And the Hilltop Institute report showed statistically significant reduction in emergency department visits, hospitalizations, and hospital readmissions within 30 days. I'd like to make 2 quick points. One is that if this program were eliminated, as you heard, the resources from local hospitals and local jurisdictions are no longer there. And the analysis takes the full $10.8 million anyway, both the state share and the federal share. So that would fully eliminate the program. And secondly, when we're thinking about expansions, there seems to be a general understanding in the analysis that we should adopt this last in, first out philosophy. This doesn't acknowledge, if I may, that a lot of analysis goes into the cost neutrality of these expansions through the waiver approval process. And these expansions like dental care and ACES and the Healthy Babies Equity Act save Marylanders money at the same time that they critically change lives. So thank you for the opportunity to testify today.
Thank you for your testimony. Appreciate it.
Good afternoon, Chair Shetty, Vice Chair Jones, members of the committee. My name is Joe Wynn.
Could you bring the mic closer, please?
Yes, ma'am. Can you hear me now?
Thank you. These
that
are
better?
new mics, and we're trying to figure
worries.
out the kinks. Thank you.
No worries. For the record, I'm Joe Wynn. I'm the Executive Director of the Maryland MCO Association on behalf of the 9 Medicaid MCOs that help arrange care for the Health Choice Program. Here in support of the governor's proposed budget. The governor's budget preserves Medicaid funding, and it's critical for program integrity, but also to maintain and maximize federal matching dollars. As you know, Medicaid is the healthcare safety net program in this country, and in Maryland, that's around 20% of our residents rely on Medicaid for comprehensive medical care, as well as prescription drugs and a host of other benefits. About 40% of all births in the state are financed by Medicaid, and the majority of folks on Medicaid mostly are kids and moms, but there's a sizable portion of childless adults who are mostly employed, but still in need of assistance. This is a strange and unusual time in our country, as you all know, and preserving Medicaid funding is critical now more than ever. You heard the Deputy Secretary speak about this. Following the public health emergency, we've seen significant swings in membership. Our own financial analysis suggests that there's greater acuity in that population, which translates into a sicker population in need of more services and more benefits. Medicaid's a joint state and federal program, and the changes as outlined by a couple of the questions and the feedback from the Deputy Secretary are on point. Even small changes to programmatic areas in Medicaid at the federal level would have catastrophic effects, not only to the program, but to the members that receive them, as well as our ability to financially control the flexibilities involved with the program. So, Madam Chair, I'm happy to answer questions, but again, we're hopeful for full support of the Medicaid budget.
Thank you so much.
Good afternoon, Chair Shetty, Vice Chair Jones, and members of the committee. My name is Nicole Grainer, and I'm the Director of Government Affairs and Public Policy with the Community Behavioral Health Association of Maryland. Our 87 members provide mental health and substance use services to the majority of individuals in Maryland's public behavioral health system. I want to start by acknowledging Director Moran and his team for their leadership through the transition to our new ASO. As with any transition of this size, there have been hiccups along the way, and we appreciate the team's oversight and dedication to support a smooth transition. 1%. To a lot of us, 1% isn't much, a rounding error at best. But to behavioral health providers, 1% can mean the difference between offering a cost of living increase to their direct care staff, many of whom do not make a living wage, or asking them to hold off until next year when maybe the money will be there. Maryland is in a behavioral health crisis. We have half the number of workers we need to meet the demand for care. Families are waiting weeks or longer for essential treatment. Providers are struggling to keep their doors open, losing staff to better paying jobs, and unable to meet the overwhelming need for services. Yet today there's a recommendation to cut the already modest 1% provider rate increase. This is not just a budget adjustment. It is a decision that will further erode Maryland's already fragile behavioral health workforce. For decades, behavioral health providers and the individuals they serve were left behind. Before the mandated rate increases from the HOPE Act in FY17, provider rates increased by a total of 12% over 20 years. The increases from FY17 to 24 allowed providers to begin to recover from those decades of underfunding. The MHCC workforce assessment confirms what we already know. Pay is the #1 factor in addressing this crisis. Without continued investment, we will lose more workers, more programs will close, and Marylanders will be left without the care that they desperately need. I want to end by thanking and acknowledging the room full of behavioral health advocates here today wearing blue buttons like mine to oppose behavioral health cuts. Together, we urge you to reject the proposed cuts and fully support Governor Moore's budget. Thank you.
Perfect timing. Great job.
Thank you.
Thank you.
Good afternoon, committee members. My name is Alistair Chang, and I am here on behalf of Fabric Health, which is a community-based organization that helps families get, understand, and use their benefits by meeting them where they are, specifically in laundromats. And we use the 2 hours that millions of Marylanders spend waiting in laundromats each week to turn a routine chore into an opportunity to engage them in their health and well-being. And week after week, we see how your constituents are missing critical healthcare communications due to outdated contact information, language barriers, limited digital access, et cetera. And by meeting them where they are, we help bridge these gaps and improve health outcomes. Our work is just one example of how proper Medicaid investments are essential to keeping Marylanders healthy. And to take some of the things we were saying and turn that into an actual story, just last week, a mother we assisted in Prince George's County was unaware that her Medicaid had lapsed after missing a renewal date sent to the wrong address. By the time she realized she was uninsured, she was pregnant, caring for 2 children, both of whom had gone years without a doctor's visit. And through our partnership with the Maryland MCO Association and individual MCOs like Care First, we helped her complete the re-enrollment process, apply for additional public benefits like SNAP, schedule medical appointments for her family in-network, and today she's no longer rationing food and able to actually take her kids to the doctor for the first time in years. Without sustained Medicaid funding, services like ours are very much under threat of being cut. And specifically, I would like to call out with one more anecdote from the time that we spend with your constituents to back up what was said earlier. Please don't lower projections for Medicaid enrollments. We're already seeing in the last week a surge of folks who have been laid off, federal contractors specifically, who are now working with, and we've got this huge backlog of folks applying for Medicaid with us in the laundromats. Thank you.
Thank you all for your testimony. Such a unique panel, right? With so many different interests represented. And just, Mr. Chang, I had never heard of Fabric Health before, but that's a very, very interesting model. So thank you all for the work that you do. Do any members, okay, Delegate Ruff has a question.
Thank you, guys, all for what you do for our state. I wanted to ask Ms. Grainer, can you give us an idea of why we are lagging behind other states as far as compensation for behavioral health specialists?
You know, it's a really good question. I think a lot of it is that underfunding I mentioned, the 20 years of underfunding. We went many, many years without rate increases, and for that, you know, there's oftentimes where I came to CBH from a direct care service provider, and we didn't get raises for several years. So that just sort of compiles on top of itself. And then there's the cost of living that comes with being in Maryland. So like compared to like Virginia and Pennsylvania, I think the MHCC workforce report, on paper, we look pretty adequate, but when you factor in cost of living, we're looking at about a 5 to 10% differential.
Thank you so much. Other questions from the subcommittee? Great. Thank you so much, panel. Appreciate you. Next, 4 people we have signed up is Dana Kaufman on behalf of Lifespan MADS MNCHA, Drew Vetter with MedChi, Danielle Meister with the Department of Housing and Community Development, and Stephanie Clapper with Maryland Citizens Health Initiative. So 4, 3, 4, great. Okay, you can begin when you're ready. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair. I'm Drew Vetter on behalf of MedChi, as well as the Maryland Academy of Family Physicians. We support the Medical Care Programs Administration's budget as introduced by the Moore administration. The proposed budget for FY26 recommended that evaluation and management codes be funded at over 100% of Medicare. The DLS recommendations propose cutting those rates to 98% of Medicare. The administration's proposal in part reflects a cut that was made to provider rates last year in FY25. Maintaining this cut into 26 will have a detrimental impact on healthcare access for Medicaid patients. E&M rates cover primary care services for Medicaid patients. Primary care is a critical component of the AHEAD model, in which success really hinges on preventative care that keeps patients out of hospitals. Lower reimbursement rates will mean lower participation by providers, as physicians may struggle to cover expenses. Not having enough participating providers in the program means that Medicaid patients may experience longer wait times for services, have to travel farther for care, or struggle to find a provider at all. These patients deserve access to treatment, and it's imperative that we set ourselves up for success under the AHEAD model. So we respectfully request that the subcommittee maintain funding for E&M codes as proposed by the administration's budget. Thank you.
Thank you for your testimony.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. For the record, my name is Dana Kaufman. I'm here on behalf of Lifespan, MADS, and Minka. We support the proposed budget put down by Governor Moore, and we would ask that you oppose the 2 recommendations in the analysis, the 2% rate reduction to home and community-based services, and then the reduction of the 1% rate increase. As far as the 2% reduction to home and community-based services, I do want to point out that these are your community providers, your medical adult daycare, your private duty, your personal care, your assisted living providers that participate in the Medicaid program. These providers have also been historically underfunded, which was documented beginning in 2018 with a report by the Hilltop Institute. These providers have also already been devastated by the COVID-19 pandemic and have been struggling to get back to pre-COVID-19 levels. Just as a reminder, medical adult daycare providers were the only providers that were shut down for an entire year during COVID-19. When you look at page 52, it says that this saves the state $3.6 million. I guarantee you that if this rate cut is taken and providers can no longer participate in the program, it will cost the state more than $3.6 million, because it's not that care will not be needed for the individuals that they care for. It's just that care will need to be given in higher costs environments like hospitals and nursing homes. So we do ask that you reject that recommendation. And then as far as the 1%, I do want to clarify that rate increases for these long-term care services and support providers have been the result of the increase in minimum wage. That increase in minimum wage, the 4%, that has become the floor and the ceiling. There were no additional rate increases given for the increased cost to provide care. So the 1% we believe is necessary. So we would appreciate it. Thank you very much.
Hi, thank you, Chair Shetty, Vice Chair Jones, and committee members for the opportunity to testify today. For the record, my name is Danielle Meister. I'm the Assistant Secretary for Homeless Solutions at Maryland Department of Housing and Community Development, and I'm told that my presence here today is perhaps unprecedented to testify on another agency's budget, but that should tell you how important this program is to us. So I'm here to testify in support of the ACES program, which is a key resource to achieving the Moore-Miller State Plan on ending chronic homelessness and DHE's vision to making that a reality. The 4 counties that participate in ACES have creatively deployed these resources with local vouchers, with local housing resources to create new permanent supportive housing, almost 500 units total in the 8-year timeframe. And we've accelerated housing outcomes, reducing the length of time that people experience homelessness in our state, while at a nationwide level, it's going up. Until this year, the state match requirement was passed through to local governments, and the net effect of that is that rural areas really couldn't participate. It's kept these resources out of certain parts of the state because they couldn't come up with that match. So counties, the critical issue for us is counties have not raised or budgeted for these funds in fiscal year 26 to take over that local match requirement. A reversal of state match at this stage would mean eliminating services for up to 620 folks who are currently enrolled, as well as preventing that statewide expansion that MDH already shared about. Additionally, how it impacts us at DHCD, we just opened a LIHTC competitive round that incorporates homeless preferences for the first time. 15% of the new affordable housing units we create will have a preference for homeless individuals. We're really relying on ACES to be the entity and the funding source to provide those supportive services for the people going into those units. So while the primary outcome of ACES is intended to improve health and reduce homelessness, it's also a smart fiscal choice for the state. Every dollar that's invested of state funding is matched 1-to-1 with federal dollars. Nearly a third of visits to the emergency department each year are people who experience chronic homelessness. And at over $9,000 per average visit, that adds tremendous cost to the healthcare system, especially when 80% of those visits could have been prevented through preventative care and being housed. So for all those reasons, we respectfully request that ACES be fully funded this year, not just for the current participants, but really to enable that statewide expansion. Thank you.
Chair Shetty, Vice Chair Jones, and members of the committee, thank you for this opportunity to testify today. I'm Stephanie Clapper, Deputy Director at Maryland Citizens Health Initiative, and our mission is quality, affordable health care for all Marylanders. And I'm here today to ask you to please fully fund Medicaid and protect Marylanders from Medicaid funding reductions. We in Maryland are leaders. We've done innovative programs like the Easy Enrollment Program to make sure people can get into the coverage they need. And expanding access to health coverage has saved millions and millions of dollars in health costs, because when people can get the care that they need in their community, they are less likely to have to go to the emergency room, which is the most expensive place to get health care. And that helps all of us by stabilizing our premiums and reducing emergency room wait times, which is critically important as Maryland has the worst wait times in the nation right now. We oppose reductions in provider rates. Reductions in provider rates would make it less likely Marylanders could get the care that they need in the community. We oppose reductions based on estimates that enrollment in Medicaid programs will not be at lower levels than those included in the governor's budget. As we've heard today, there are a lot of layoffs happening right now, and we expect that enrollment in Medicaid could go up. We thank the Maryland General Assembly for critical programs like the Healthy Babies Equity Act, adult dental coverage for Medicaid enrollees, and the Trans Health Equity Act, and we ask you to please do everything that you can to protect these programs, as repealing these programs would have significant harm for the Marylanders who are relying on them for their health care. Together, we have made great strides in Maryland. We are leaders in the nation. I thank you for that leadership and ask you to please fully fund Medicaid and protect Marylanders Marylanders from cuts. Thank you.
Thank you so much, panel. Do any members of the subcommittee have questions? Thank you for your testimony today. So we have 6 people left, but 2 of them are from the same group. So I'm going to go a little out of order and have the 4 that are not from the same groups testify together, and then CASA, your 2 people can testify together last. So Teresa Titus Howard from the Coordinating Center, please. Ashley Woolard with Public Justice Center. Kevin Slayton, Maryland Center on Economic Policy. And Brig Dumais with the Trans Rights Advocacy Coalition, please. Is that 4? Perfect. Okay, thank you. You can begin when you're ready.
Good afternoon, Madam Chairman Chetty and committee members. My name is Teresa Titus Howard, and I'm the president and CEO of the Coordinating Center. We're a Maryland statewide nonprofit case management agency serving nearly 10,000 Marylanders living with complex medical needs and/or intellectual or developmental disabilities. We've been a home and community-based services provider for over 40 years in the state of Maryland. I'm here today to oppose the proposed 2% home and community-based provider rate decrease, and here are my reasons why. As a case management provider, we facilitate opportunities for Medicaid waiver participants to receive services in their homes rather than institutions. Every day, we focus on our mission, which is to support our clients achieving their aspirations for independence, health, and a meaningful community life in their home of choice. A current client is a 60-year-old man unable to mobilize due to quadriplegia who had been living in the nursing home for 3 years. When the case manager first met this individual, he was lying in his nursing home bed, and he told her he dreamed of returning home. Through his case manager's collaborative partnership with the MDH office and LTSS, this individual received his waiver approval on December 30th, 2024. His waiver plan of service was approved on January 6th, and I'm happy to share that our client moved home on January 28th, where the client there was met by his children. While he was nervous about going home at first, he stated that he's truly happy to sleep in peace. This is just one example of the 10,000 people served by the Coordinating Center. I'm concerned about that the proposed 2% rate decrease will have a serious impact on services for people in home and community-based waivers. By reducing rates, we will be forced to reduce staff and increase caseloads, thus putting Marylanders at risk of receiving timely services. Marylanders will be forced to wait longer for approval of plans, remain on waiver waiting lists longer, and as a result could end up and remain in institutional care. Thank you for the opportunity.
Good afternoon, committee. My name is Ashley Woolard. I'm from the Public Justice Center. I'm the lead attorney for our Health and Benefits Equity Project. We respectfully, we support the governor's budget and oppose cuts to Medicaid's budget that impact community members' access to care. The General Assembly over the years has passed and funded incredible and innovative reforms to our healthcare system and Medicaid beneficiaries. Before adult dental coverage, I was hearing devastating stories from community members who could not afford necessary dental care. Many had broken or missing teeth and were going to the emergency room for pain management and antibiotics for chronic pain. The General Assembly passed comprehensive dental coverage for adults to give them access to care and prevent dental infections like the one that took the life of 12-year-old Marylander Diamante Driver in 2007, who was the child of one of our clients. Undocumented birthing people had to wait to learn vital information about their baby's health until they went to the hospital to deliver because Medicaid did not cover prenatal and postpartum care for them. I was fortunate that through my job, I had comprehensive prenatal and postpartum coverage for my high-risk pregnancy in 2021, ending in an emergency C-section, and thankfully birthed a healthy baby and now 3-year-old Eris. From start to finish, I had the information I needed to know that she was okay. I cannot imagine how terrifying it would be to birth in informational darkness. Through the Healthy Babies Equity Act, we're providing a path to timely care that helps us prevent pregnancy-related disparities and deaths in immigrant communities. And the collaborative care model allows primary care providers to coordinate with mental health providers to meet both somatic and mental health needs of patients. And for many Marylanders, primary care is often the first path that they take to communicate mental health needs and connect to care. We know that you have some really difficult budget decisions to make this year, but we do ask that you preserve the funding for Medicaid programs, many of which are intentionally rooted in our state's commitment to advancing health equity. Medicaid isn't just an entitlement program, it's a lifeline to care for low-income individuals and families. Thank you.
Good afternoon, Madam Chair and members of the committee. My name is Bridge Dumais. I am a co-leader with the Trans Rights Advocacy Coalition, known as TRAC, a statewide coalition that fought to pass the Trans Health Equity Act and the Trans Shield Act. Our coalition includes trans people and allies, healthcare providers, parents, and attorneys. We are alarmed to see the budget analysis suggest that newer Medicaid programs, including gender-affirming care, be considered for cuts. Every major medical association states that gender-affirming care is medically necessary, life-saving health care. This is especially true for Black trans people. TRAC strives to center trans joy. So instead of listing out all of the traumas that members of our community face without access to gender-affirming care, let's instead focus on the fact that when people who need this care can get it, overall quality of life improves. They're more likely to live safer, healthier lives, hold stable employment, and maintain housing. In the context of the whole budget, funding for gender-affirming care is a relatively small amount that not only goes a long way to improve quality of life, but can also lead to cost savings in other areas. When people have the care they need, they're less likely to be hospitalized, need emergency shelter, or depend on other social safety net programs. And TRAC stands in solidarity with other communities fighting against Medicaid cuts as well. We will not be pitted against each other because we all deserve care, and healthcare workers deserve livable wages. Conversations about cutting Medicaid in response to what is happening on the federal level are preemptive, as cuts have not been passed or implemented yet. The money is still there to provide care now. We understand there is a budget shortfall in the state and that tough choices will have to be made. However, before considering cuts to vital programs like Medicaid, we urge the legislature to address revenue shortages by closing corporate tax loopholes and ensuring the wealthiest Marylanders pay their fair share. With these solutions, there is enough money for everyone to get the health care that they need. We urge the committee to fully fund Medicaid. Thank you.
Thank you so much. Go right ahead.
Good afternoon.
Oh, could you? Thank you.
Good afternoon to the chair and the vice chair, the committee members, and if I may just take some privilege and say to the OG in the room, the original appropriations chair, my friend Maggie McIntosh. Good to see you. I'm Kevin Slayton. I represent the Maryland Center on Economic Policy. And we are here in support of the governor's budget proposal for medical care programs administration. However, we are alarmed by some of the suggested cuts that were on the table for the considerations within the DLS analysis. We recognize that there are real threats to Medicaid from Congress, and if those cuts happen, they will harm a lot of Marylanders and require impossible decisions here at the state level. However, we are not there yet, and those potential cuts are deeply unpopular and may actually never happen. We should not get ahead of the process and start preemptively taking away Marylanders' health care. Health communities with access to affordable care are critical to a healthy economy. We believe that. And I also want to comment generally on some of the approaches that Maryland has tended to use in addressing budget challenges. Freezing or cutting provider rates has in the past made it harder for people to access essential health care because they can't find providers that are willing to accept Medicaid. And focusing on programs just because they were enacted more recently, we believe is a rather misguided approach. Programs like Healthy Babies, Gender-Affirming Care, ACIS, and dental care for adults were thoughtfully enacted with a lot of community input to address current needs. These programs are working, and they're all expected to decrease costs over time by reducing emergency room visits and preventing people from developing more severe and costly to treat health needs. We have no issue with the fund swaps and technical fixes, but we strongly urge you not to go down the path of taking away essential health services from vulnerable Marylanders and pausing programs that are working and improving the health of folks in our communities. Please stick with the governor's proposal, the proposal that it does not make these harmful cuts. Finally, we agree with the department that the budget should not assume lower Medicaid enrollment, as many Marylanders are currently facing layoffs and an uncertain employment future. Thank you.
Thank you so much. This panel was also extremely compelling. Really appreciate your testimony. Any questions from the subcommittee? Okay, thank you so much. So we now have our two final witnesses that have signed up, Ninfa Amador Hernandez and Lady Garcia. Forgive me, I feel like I probably mispronounced that wrong, incorrectly. I'm sorry. And I know, Dan Shattuck, you had also asked if there's 2 minutes extra, so I'm going to let you come to the table and you can have 2 minutes as well. And then whenever you all are ready, you may begin.
Ready? Good afternoon. My name is Lady Garcia. I'm the Senior Health and Human Services Manager at CASA. I'm here to support the continued funding of the Healthy Babies program. As a health and social services provider, I have witnessed firsthand the profound impact this program has on our communities, especially for communities members who had no other access to health care. The Healthy Babies Equity Act was established to combat alarming disparities in maternal and infant health outcomes in Maryland. Its primary focus is to provide resources and support to low-income families, ensuring equitable access to prenatal care, education, and essential health services. The impacts we have seen are a testament to this much-needed public health program, which has also relieved the financial burden of healthcare on families and the strain on the healthcare system when individuals can seek preventive care. Research constantly shows a direct correlation between access to prenatal care and infant mortality. For instance, Black and brown infants in Maryland experience a mortality rate that is more than double than of white infants. Cutting these findings will severely hinder efforts to close the unacceptable gap. However, in communities where the program operates, we have already seen significant reductions in infant mortality rates. We cannot regress on this progress. Healthy Babies especially targets marginalized communities that face systematic barriers to healthcare. The program has ensured that low-income families struggling to access necessary services do not have to face worsening health disparities, especially for bearing parents during such a critical time as the perinatal care. Without the support of the Healthy Babies Equity Act, families might face a higher out-of-pocket expenses for healthcare services. The strain on healthcare systems cannot be overlooked as well. We continue providing families adequate prenatal care and postnatal care in order not more prone to complications that require emergency intervention. By investing in health equity today, we're investing in a stronger and more prosperous Maryland for tomorrow. CASA urges you to prioritize funding for programs that support healthy beginnings for all babies and families in Maryland. Thank you for your consideration.
Thank you for your testimony. Final 2 minutes, sir.
Thank you, Madam Chair, for allowing me the ability to testify today. Thank you, members of the committee. A special thank you for your openness and your open door and always willingness to talk to us as we try to solve problems and work through the challenges. And as we've heard today, Medicaid is facing a lot of challenges. For the record, my name is Dan Shattuck. I'm here on behalf of Bricado and Shattuck, and we represent a number of healthcare clients in the Medicaid space and in the commercial space as well. I want to thank the Deputy Secretary Moran for his hard work. We've come to him often with questions and needs for reports and studies, and we want to continue working with him on a number of those, one being the maternal fetal medicine study looking at E&M codes and procedural codes that haven't been updated in about 10 years. And we understand the challenges being faced financially with Medicaid. And that's going to jump me to another provider group, anesthesiologists, that are integral to the Medicaid healthcare system in the state of Maryland. They often don't have the ability to discern what insurance coverage their patients are under. They treat anybody and everybody that comes to them, as do our emergency physicians. So we come to Medicaid often to look at E&M codes and provider rates, and we thank the department first and foremost for bringing up E&M codes to over 100%. But what we've come to realize is Medicaid can't fix this problem all on its own, as much as we would like. There needs to be some cooperation with the commercial insurers as well. Not every patient is a Medicaid patient, but the more Medicaid patients that are seen by our providers, the disparity between Medicaid rates and the commercial rates become increasingly clear. and that becomes an access problem. I don't want the gray beard to fool you, the youthful appearance, but I've been around Annapolis for quite a while, and I remember the mantra when it came to Medicaid expansion was no wrong door. And I think we heard that with Fabric Health. There really is no wrong door. We want people to get access to Medicaid, but what happens when they come through that door? We need the workforce. We need to continue working with Medicaid. We need to bring in other entities to help stabilize the broader workforce so that they're there to treat those that need it most. Thank you.
Thank you, Mr. Shattuck. Any questions for our final panel? Seeing none, thank you for being here. Thank you to all for joining for today's hearing. That concludes our budget hearing on Medicaid. We are adjourned.